So let's talk about this easy case today. And this is a male patient with the central corneal opacity with around 8 diopters of myopia. He came to me with one request: doctor, please remove my glasses and give me some clarity. Because he had a presenting vision of counting finger at 2 meters, unaided, and as soon as we gave him 8 diopters of myopic correction, his vision got to 612, although it was not clear in the central axis, but still he requested me to get off his glasses. As more and more of these young patients present to you in the OPD with the same requests of removing their glasses, the common request that I get is their financial constraints these days, especially in the developing countries where myopia is increasing at a very fast pace. This man requested me and I took up this case. We did not have any option to decrease his myopia, but I thought that I'll go with a refractive lens exchange in this patient with a central corneal opacity. There are a few points to note which are important in this case, and yes, you can see the central corneal opacity. As far as I remember, the patient had a history of trauma since he was a kid and did not have the budget to go around having an optical PK sort of things. So I decided that I'll go ahead. The things to note are just two simple things. It will be a simple case. One is always stay in the capsule in these cases, because these young patients tend to have a very elastic capsule which is prone to rip apart. So yes, I have dyed it with trypan blue and I have completed the rhexis going around in the periphery of the corneal opacity. All the other steps will be as similar as my other cases. I have made two side ports, limbal in location with minimal blood vessel cut, and I have made a main port that is around 2.8 mm in width. Tip number 2, very important, I'll make these multiple hydrodelineation and hydrodissection waves which will just ease and just pop that endonucleus out for me, because as my visibility is poor, I won't be able to get hold of the details of the capsular bag. So I am just making these multiple waves so that they aid me in the phaco process. Yes, as you can see, this baby like endonucleus, one pole is out of the bag and I'll just grab it with the vacuum of the phaco. I don't even need to put a lot of US energy in the anterior chamber. I have grabbed a dialer specifically and strategically because my visibility is poor in the center. Tip number 3 is very important. Never take your phaco tip towards the periphery of the bag especially in these cases where your visibility is poor. Yes, visco can aid your magnification and clarity in these cases, but I felt confident operating this case, so I have kept it as normal as I can. So these were the 3 tips, and I wanted to share this really easy and fun case. Refractive lens exchanges are very common and you should be really comfortable operating them. So yes, just like that, we are down to 70% of the nucleus, only 30% of the epinuclear shell and the cortex is left. Surprisingly, there is not a lot of cortex and I won't need to just clean it up with my irrigation aspiration. And here we go, the case is about to finish, and yes, the last bit has come up. The anterior chamber has held well, and as you can see, this beautiful brilliant glow, just like that, -8 diopters of myopia has gone, and we'll be implanting him a monofocal lens. And I remember him smiling in the post operative day one, and it is really gratifying when you remove the glasses of these patients at such a low cost, especially in India where the healthcare has been made affordable by a lot of government schemes. And when these patients come up with these requests of affordability, you have no other option but to operate them at a minimal cost. For my American friends who watch my channel, you'll be glad to know that we have worked really hard bringing down the costs of surgeries to as minimum as, I guess it's even less than $100, the whole surgical procedure, and that is free for the patient. So yes, it's a monofocal lens. It's an aspheric 360 degrees square edge IOL, which gives these patients brilliant result at no cost to the patient. These patients hail from underprivileged backgrounds, and I'm just a tool in the hands of God and feel really blessed to help these patients out. So minimal cortex has been left, and I'll be aspirating it with my irrigation aspiration. I strategically took this step up of implanting the IOL first and then going with the cortex removal because of the visibility in the center. But yes, I'm just taking out the visco. I'm just going to conclude the case now. I hope you like my videos. I have seen that 50% of the viewers of my channel have not subscribed, so it would be a very humble request for all the viewers who are here to please subscribe my channel. That's all from my side. I hope you like my videos. Kindly like, share and subscribe. Thank you so much. This is Dr. Simanchal Goyal signing off. Have a great day ahead. Bye bye.